We are the Center for Advancing Health Outcomes, research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
I will just give it one more minute to let our waiting room folks come in. And then my name is Skye Barvik. I use she, her pronouns. I'm an associate professor at the Department of Occupational Science and Occupational Therapy at UBC, and advancing health scientists as well, and big fans of Angela and Michelle. So I get the privilege today of introducing them. Before I begin, I just want to acknowledge my place of work today is on the unceded ancestral territory of the Coast Salish people, specifically the Squamish, Tsleil-Waututh, and Musqueam people. I'm very grateful to work, play, and live on these lands. And I'm really grateful to meet new people in my journey too. And Michelle and Angela have been great people who I've been learning a lot about their programs and research. I'm very excited to be able to introduce their talk today and introduce them as humans, as researchers, as colleagues. That's okay. So I'll start with Angela, and I'm going to read here because I was given your bio and it's long, so I didn't memorize it, but here we go.
Abbreviate it if needed.
Dr. Angela Russolillo is an assistant professor in the School of Nursing at the University of British Columbia, specializing in health services research. Her clinical training and experience has informed her program of research, which focuses on health services use for people with mental health and substance use challenges. Dr. Russolillo aims to reduce disparities in mental health and substance use treatment through health service reform, advocacy, and integration of evidence-based practices. Dr. Russolillo is a Michael Smith Health Research Scholar in the Health Professional Investigator category. They collaborate with locally and nationally on initiatives to improve patient outcomes by promoting comprehensive and compassionate care. Her research not only advances academic knowledge, but also influences health policy practice, providing practical solutions for better mental health and health services delivery and patient care. Michelle Carter is a clinical nurse specialist at St. Paul's Hospital and a doctoral trainee in the School of Nursing at UBC. She aims to strengthen perinatal mental health services to support the complex and evolving needs of birthing people and their families. She is particularly interested in the development, implementation, and evaluation of evidence-based nursing interventions. In her clinical role, Michelle leads and contributes to the creation of interdisciplinary guidelines, clinical tool, and evaluation frameworks that many of us have benefited from that advance perinatal and mental health care. She also guest lectures at the UBC School of Nursing on topics related to mental health and nursing leadership. So thank you for today, and I'll pass it to you to introduce your talk. And I'll take questions at the end or field your questions at the end.
Great, thanks so much, Skye. I've been given the thumbs up that everyone can see the presentation. If that changes, please signal to Michelle or I. Really delighted to be here today. I was just reflecting with Skye on the fact that Michelle and I have wanted to present on this work for quite some time, and this seemed like a good opportunity. And so we'll be talking today about sort of two independent studies that were undertaken using a Delphi-derived methodology to support consensus making around frameworks for care. We'll get into those details, but I also just want to acknowledge that all of this work did take place within BC and within the context of our work both at UBC and at St. Paul's, and we're grateful to acknowledge the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations, as well as all of the participants who provided very valuable feedback to this process. And so we just want to upfront make sure that those folks' contributions are acknowledged and recognized. So we are really kind of going to focus on, let's see if I can click through here. We're really going to focus on just sort of a brief context around some of the current BC climate with respect to mental health and substance use care that's driving some of the challenges we're seeing. Michelle and I will take turns talking independently about the methodology and development of each of the models of care that were derived. And then we'll discuss sort of in context some policy and practice implications and share some concluding remarks about what we've sort of seen across both of these projects and how that can support future work and kind of redesigning care in the province for folks experiencing mental health and substance use challenges across the life course. we're just, Michelle and I both are affiliated with UBC. I receive funds from Michael Smith, and Michelle received funds from CIHR and Michael Smith. We have no conflicts to declare, and we're really excited to be here today to talk about this work. So I'm going to start with a bit of introduction, and then I'll hand it off to Michelle. And if you have any questions, please feel free to put them in the chat box. So for many folks who are in BC, you'll be kind of acutely aware of some of the challenges we've been seeing in the context of mental health and substance use care delivery. We're currently kind of have been experiencing ongoing opioid and unregulated drug crisis, resulting in significant mortality across the province. We're seeing increases in wait times for folks receiving mental health and substance use care. And that's really been highlighted recently in the context around mental health legislation and the push for increased use of involuntary services to support folks experiencing mental health and substance use challenges. You know, one of the things that we understand sort of that's effective from an evidence-based perspective is sort of thinking upstream, thinking preventative, and offering folks services in the communities where they live, and using sort of a model of care that supports choice, autonomy, and is backed by evidence. Lots of people in our province experiencing mental health and substance use challenges, you know, 1 in 5 people annually, that's 5 million people. And so there's a lot of folks that are unfortunately not receiving the care and services that they need. And that includes folks who are presenting with, you know, specific challenges that might complicate kind of the traditional path in the way traditionally our health services are set up. So folks who have co-occurring mental health and substance use disorders, individuals who might be in the perinatal or postnatal period, birthing people, folks who come in with specialized, unique, requiring additional sort of specialized services that we traditionally kind of have been challenged to provide kind of consistently and without a lot of weight or barrier for folks. You know, and some of the other challenges we're facing as a clinical community and as a health service community is as clinicians are kind of working with really limited resources, navigating sort of increasing complexity in both patient populations, but also in kind of the way in which the systems we operate in are set up. And so as a clinician and as someone who has worked for many years in the mental health care sector, I'm acutely familiar with some of those challenges and some of the ways in which policy doesn't align with practice, and some of the ways in which practice is not evidence-based, but is reliant on kind of historical ways in which we've operated and provided service delivery. And so one of the things that I think we've seen is we've been operating in a way that we've been looking to sort of like provide Band-Aid solutions to a lot of complex challenges, and we haven't actually targeted upstream what some of those issues are. And one of the kind of key issues that we see is this lack of service integration and the lack of ability for folks to navigate freely between community, acute, and other services to access those services in a way that's meaningful for them. And also to ensure that we are not taxing folks in a way that makes it difficult for them to seek out services in a way that's supportive. We want to kind of operate in a way that's ensuring that we're not coercive and we're not forcing folks into treatment when we actually haven't addressed some of the upstream systemic barriers that prevent them from actually accessing those services or receiving supports in the community. And so one of the things that has really sort of come through for me in my own body of work and my own understanding of what's happening is this idea of multimorbidity. We've really been seeing an increase in the kind of individuals presenting with multiple co-occurring, intersecting health challenges. So that might, in the context of mental health and substance use, that's often people with multiple mental health challenges, as well as substance use challenges and physical health issues. And unfortunately, this sort of increase in multimorbidity is driving kind of challenges in how our system operates. And so while multimorbidity traditionally sort of stemmed out of an older adult paradigm and frame of understanding care, there's been recent calls in sort of psychiatry and other disciplines to acknowledge the fact that this is now sort of something that we expect to see. It's no longer sort of the exception to the rule, but our systems and services haven't really adapted to meet those needs. Other folks have sort of reflected on some of these challenges as what we would call sort of wicked health problems, problems that lack definitions, agreement on solutions. There's no linear solution to solving these. And other folks have sort of lamented in kind of the complex systems theory kind of frameworks reflecting on what we see as sort of this edge of chaos. So where the care of patients with sort of multiple clinical and social needs lies at this sort of intersection between complex and chaotic, and there's really no clear path to a solution without significant sort of upstream changes to how we resolve these issues. And so as someone who's sort of acutely interested in service delivery and ensuring access and accessibility for folks who need services across the life course, I've sort of kind of tried to conceptualize some of this as we worked through some of the models that we've developed. And so our focus today is sort of to highlight how we think some of these integrated models we've developed both prioritize people with lived experience in the development, but also shape a system that is focused on addressing some of these current challenges that we have yet to see resolution to, particularly in the mental health and substance use space. I'll leave you with just one kind of final comment, in that like what we need to stop doing is trying to kind of use this sort of reductive approach to how we solve solutions, and we need to start thinking more dynamically, emergently, creatively, intuitively to solve some of these challenges. And so I hope that sort of sets the stage for where Michelle and I have sort of both come from with designing these frameworks and wanting to see some change in this context. I'll hand it over to you, Michelle.
The joke between Ange and I the last little bit is that both personally and professionally, we've been operating at the edge of chaos. So I'll provide a little bit of background on perinatal mental health in our Delphi study, but I wanted to start by saying that the path to this work wasn't a linear one, and it was also one that I didn't feel like I could ignore. So when I had my daughter, Mackenzie, 5 years ago, it felt as though everywhere I turned, I saw the impact of pregnancy and parenthood on mental health. And you know, as I was fumbling through my own sleep deprivation and breastfeeding, I was also attempting to support friends and family members who were suffering from the mental toll that comes from miscarriages, emergency C-sections, NICU admissions, new onset depression and anxiety. And as life, or as luck would have it, when I returned to work from that leave, I was invited to work clinically in practice in the reproductive mental health clinic at St. Paul's, and you know, where I saw some extraordinary efforts, I also saw some very real health system challenges. So long clinic wait times, siloed care, a lack of resources, and felt that there had to be a better way. So this research has been really in pursuit of that, to find a better way, a more integrated, connected way of providing perinatal mental health services to those who need it. Okay. So some of you may know perinatal mental illness is an umbrella term that most commonly refers to depression and anxiety, but also includes bipolar disorders and psychosis occurring in pregnancy and up to the first year postpartum. And these illnesses are very common. It's estimated to affect at minimum 1 in 5 birthing individuals. And importantly, we know that when left untreated or undertreated, these illnesses are associated with poor maternal and infant outcomes. So we see an increased risk of future maternal mental health challenges, obstetrical complications, preterm birth, impaired infant bonding, impaired infant development, and rare but very severe cases, attempts at maternal suicide. I think the upshot of this, and what keeps me grounded clinically and in my research, is that there are highly effective evidence-informed treatment options available. So, unfortunately, in our current state, though, very few individuals with perinatal mental illness are identified or receive timely treatment. And as Ange mentioned, there are many complex reasons for this. Perinatal mental health patients often have a very complex clinical profile. So your obstetrical, medical, mental health, psychosocial needs that all intersect. It can be really difficult to disentangle symptoms of pregnancy from mental illness, like fatigue, sleep disturbances, low energy, And we're also operating in a health system where there are limited resources, very few specialized perinatal mental health clinicians, and fragmented care. So we see this across specialties, obstetrics, peds, psychiatry, but also across levels of care. So public health, primary care, outpatient and inpatient mental health services. Next slide. So with funding from Michael Smith Convening and Collaborating Award, I had the privilege of working alongside a multidisciplinary team of researchers, including Angela, clinicians, and people with lived experience to co-develop an evidence-based, user-informed model of integrated perinatal mental health care. So we approached this work in several stages, and this was really my first kick of the can with research, so I think I probably made this more difficult than I needed to. But we grounded this work by first looking at the literature, so conducting a scoping review, seeking expert opinion through a Delphi study, and then holding a BC partner meeting to discuss how our findings might be made relevant to our own health system and clinical practice. Next slide. This is a bit busy, but in our scoping review, we looked at empirical studies that described integrated perinatal mental health care. And so we used Artsino O'Malley's scoping review framework and searched for databases, resulting in over 4,500 articles. And on review, we retained 45 articles for analysis. And from that, we were able to identify some very key features of integrated perinatal mental health care, taken from global examples of integrated mental health services. So from there, we conducted a Delphi study, which is an approach to seeking expert opinion and consensus on a complex issue. So for us, this involved presenting our findings from our lit review in terms of core domains and key indicators of integrated perinatal mental health care in 3 iterative rounds of online surveys. So in each round, participants, which included perinatal mental health clinicians, researchers, and people with lived experience, they were asked to review the core domains and indicators and then assess their relevance so they could determine whether an indicator should be retained, removed, or modified. And they also ranked its importance using the Likert scale. And at the end of 3 rounds, we reached consensus, which we defined as greater than 75% agreement on the core domains and indicators of an integrated model of perinatal mental health care. Next slide. So here we are. We identified 8 core domains and 45 indicators of integrated perinatal mental health care. And with input from provincial partners, we also developed a set of recommendations for each core domain. And those relate to the health system, clinical practice, and clinician education. So the full report's available at our UBC Wellstream site, linked here, which I'm happy to share. But I thought I would just touch on a few key pieces. So one of the domains, we can hang back, thanks, is person and family-centered care. And so this is the idea that patients should have choice in care, choice in the care that they receive, that care should be accessible and flexible. We heard a lot about the need for both virtual and in-person services and the need for patients to be meaningfully involved in shared decision-making around treatment. Culturally safe care also emerged as an incredibly important domain. We learned that it's important for care teams to acknowledge the history and effects of systemic racism on individual and population health and healthcare experiences. With respect to care delivery, we learned about the need for coordinated care across the continuum from community to acute care, such that information systems, clinical teams, physical spaces, protocols are structured in ways that promote communication and collaborative care planning across the illness and recovery trajectory. And for care to be truly integrated, we learned there needs to be defined strategies that address health promotion, illness prevention, screening, assessment, triage, transition planning, and a biopsychosocial approach to treatment. So we really want to identify interventions that address the physical, psychological, and social aspects of perinatal mental illness in ways that also attend to individual needs and preferences. Next slide. And so as a clinician, I wanted to touch on some practical ways that we might apply some of our findings. I think we learned that integrated care really relies on solid perinatal mental health training for all clinicians who support birthing people. So not just folks working in reproductive mental health clinics, but nurses, social workers, midwives, GPs, and obstetricians. And while there are some existing programs, I think there needs to be a lot more development in this space and also in healthcare training. Slide. And then also, given how few folks with perinatal mental illness are identified, I think we need to work towards systematizing perinatal mental illness identification, assessment, and triage for folks who might be affected. And we also need to, I think, create care pathways that reflect a range of treatment options that are adaptable to clients' needs and preferences. And I was actually connecting with some folks in Ontario who started leading some of this work. And here you see they've drafted a stepped care framework. And I think this is something that we're all working towards, the idea that we're offering the most effective, least resource intensive care first and stepping up progressively to more specialized intensive care as clinically indicated. And something that we're trialing here at St. Paul's is embedding complex care coordinators. So it's an emerging role typically held by nurses, someone we see as a quarterback that leads communication, but also coordination of individualized care across disciplines, across levels of care, across specialties, teams, and also information systems. So with that, I'll hand it back to Ange.
Thanks, Michelle, so much. It's been such a pleasure to work on this project with you and to see it come to life, and your expertise has really shone through in this work. And so congratulations on this work and all the contributions you've been making to improving care. In addition to Michelle's project, Michelle and I were also on the project that I started, which was more focused on folks experiencing co-occurring mental health and substance use challenges. And this work was funded by an early career award from Providence Research and the Curiosity Foundation. And so I will do my best not to repeat some of the methodology and methods that Michelle described, but I will kind of provide you with some context on some of the points of difference that we utilized in our approach. So similar to Michelle, a lot of this work for me was really driven out of some of the clinical challenges I was seeing. I am only very newly acquainted with sort of an academic position as of last year in July, and most of my work and research has very much been from off the side of my desk as a clinician, operating in various kind of health leadership positions. And so I was faced with a lot of challenges in trying to sort of disentangle how we were best to support folks, and kind of frustrated by the systems that I was having to work with, which didn't really acknowledge some of the clinical complexity we were navigating, but also the failure to sort of kind of recognize that we're really no longer seeing individuals with a single diagnosis. And those folks are really the clinical minority. What we're actually seeing is folks presenting with many kind of challenges, maybe multiple mental health challenges alongside substance use challenges, and largely kind of other factors around physical health issues like diabetes, and potentially even complications around like social factors, so homelessness, poverty, and all of those things together kind of make clinical decision-making more complex and more challenging. We don't have a good framework for understanding how to deliver services in that way. And so people with concurrent disorders or co-occurring mental health and substance use challenges are at really high risk for a number of adverse outcomes: mortality, poor service integration, prolonged hospitalization, limited access to services because they don't fit into the kind of linear or single diagnosis buckets that we currently operate under. And so we're seeing a lot of sort of, poor quality of life, avoiding health services because of previous negative experiences around stigma. And so all of these things create make it really challenging for folks to access services. We all know that care has been described repeatedly as fragmented, uncoordinated, siloed. These are not new terms. This has been a challenge we've been facing for decades in this province. And what we do know is that Integrated management approaches are actually rare in the current health system, even though there is documented evidence to suggest that they're best practice at this stage. And so what we wanted to do is sort of take that understanding and try to leverage it into a framework that could support kind of clinicians or health system planners to think about how they might develop this from an operational perspective, but also to support sort of thinking through some of the what was important to folks both in the health system, but also people with lived experience. So we brought healthcare providers together, researchers, people with lived experience through this Delphi study, and we were really wanting to generate some of the important elements of what integrated and recovery-oriented models of care would look like and for folks experiencing co-occurring mental health and substance use challenges. So why this model? Why did we focus on care integration? Why did we focus on recovery-oriented care? For a lot of folks, maybe who are less familiar with some of these terms, integrated care for us was really speaking to this idea of a seamless delivery of services to people across levels and types of providers. And it was really meant to focus on collaboration and integration because we know that it produces better outcomes. And recovery-oriented was also intentional because unfortunately, I think that term has been utilized and has become synonymous with abstinence, which is not the intended meaning of recovery-oriented. It actually stems from grassroots movements among folks in the mental health advocacy communities. And it really speaks to a broad range of services that are person-centered. They promote resilience. They're inclusive, they're participatory, and it is not synonymous with abstinence. And folks often, unfortunately, have used that term to be synonymous with abstinence, which really undercuts the true meaning of the inclusivity and participatory nature of sort of self-directed care for folks and autonomy and decision-making. So those were both intentional. And also, you know, there's been well-documented kind of concerns about care fragmentation, and the quote along the bottom is actually from someone from our study who identified that kind of this current model, which is expert driven and top down, tells people how things are and what the plan is going to be, and it needs to be turned on its head. And so we really wanted to ensure that we were providing some new guidance to move change forward in the care delivery system that we're currently operating in. So similar to Michelle, we used a modified e-Delphi approach. This was 3 iterative rounds of online surveys. In rounds 1 and 3, care indicators were rated on a 9-point scale, low, medium, high. In round 2, we sort of deviated from the traditional Delphi approach where we actually asked respondents questions about their experience of care. And we asked them to rank 32 treatment outcomes, individual needs, and health system attributes. So we could understand sort of what was important to folks. And then in terms of consensus meeting, we actually used what's called the interpercentile range adjustment for symmetry technique. So that actually is a quantitative measure to understand the degree of disagreement between respondents. And so that was our main way we discerned kind of what should be prioritized into the larger model. And so these are some of the participant perspectives that we yielded from round 2. And this work has also been written up as a qualitative paper, and some of the folks who are probably on that paper are here listening, and so just want to acknowledge everyone's contributions. This was a joint effort. I am not a qualitative researcher, but we thought it was really important to ensure that we highlighted some of these themes that emerged in the responses to round 2 questions about people's care experiences. And so what you'll see here in the figure is sort of an overlay of participant recommendations for change mapped onto sort of micro, meso, and macro levels. But really what we found was there was 4 key themes that folks described that were barriers to care. High barrier services and limited access to services. There was a lack of integration of mental health and substance use care, a need for trauma-informed and person-centered care, and also the need to prioritize the voices of people with lived and living experience. And so many of these recommendations for change were identified for each of these themes. And this is sort of a summary of how they map on to sort of the kind of more practice policy level context. What we also were able to develop from this Delphi study is this final model of care, which is what I'll kind of talk about in more detail here. So we developed 7 core domains, 51 indicators, The report also includes reflective practice questions, organizational opportunities for change, case studies for individuals, as well as useful links and resources. The full report is available at the project website, careforccd.ca, so please feel free to download it. What we found similar to Michelle's work is that there was a high prioritization on ensuring access to services, ensuring that folks had education and training to support the complexity that folks were facing. There was also a real prioritization of citizenship, choice, and community in how services were delivered and shared, and also kind of a streamlining of the screening, assessment, and treatment process so as to ensure that folks weren't having to duplicate kind of assessments and things across providers when you're providing the same information. And there was lots of sort of discussion around care delivery and care transitions. How do we support people navigating between different service delivery models? And so participants kind of really identified access to health services as the most important individual need, and that equitable care was also the most important health system attribute. And I think that that's says a lot about the challenges that we've been facing. And I think this kind of model of care really shapes where we could go and how we could improve our current care delivery. So the kind of final report looks a little bit like this. Each domain has its own page with a description, the indicators that are attached to that domain, reflective practice questions for health providers, and also opportunities for change for organizations if they wanted to actually implement some of these changes. So that, like I said, the full report is available for you to review. And if you have any questions about it, I'm more than happy to answer them. I think one of the key things that we wanted to sort of really leverage through this work was kind of future directions. So now we have these frameworks, what are we going to do with them? Developing services that respond to the needs kind of and realities of people accessing mental health care is really important, both at a clinical level, but also at a system and policy level. And so some of the quotes from folks when we asked them in round 2 about their experiences were that, you know, we need to focus on what people want for themselves and what they're actually going to participate them rather than paternalistic views of recovery. We need to integrate concurrent disorder teams so they work together instead of against each other. And we need to focus on early intervention, and we need to get out of this cycle of crisis response. And so some of these quotes really sort of shed light on the challenges folks were facing, but also like where we need to target our next steps and our future directions. You know, at a bare minimum, we need to, you know, as the need for concurrent disorder care grows, we need to sort of understand from the people who understand the situation best and are positioned to best to answer it, sort of how do we inform clinical practices? How do we change health systems? And how do we integrate this into policies? Ideally, there'd be an adoption and implementation of a model like this or a similar model, which would include evaluation and feedback on how it's working. And the reason for that is like we actually really need to know like what works and for whom. I think what we've been doing consistently, unfortunately, in our care delivery models is implementing models without any kind of evidence-based rationale and assuming that these work for everyone. And I think what we need to do is start looking at how we can use things like implementation science and other approaches to really evaluate the effectiveness of this work and also understand the facilitators and barriers to ensuring access for everyone. And, you know, I think ultimately one of the biggest takeaways for both Michelle and I from both of these projects was just, you know, we really need to keep in mind the people who need these services, the people with lived and living experience. And this is a quote from someone from our project who said, keep us in mind. If you want to improve this, for us, prove it. Don't forget that we are at the core of this. We are the very reason you are doing this once it comes time to set up a system. And so I think really powerfully, this should be our kind of signal and path forward to do this work in collaboration and with, you know, direct input from folks who have experience with the services and systems that they need. A few concluding remarks. I think, you know, despite that we were addressing kind of needs of different populations, both of our studies really converged on sort of 4 key points. You know, like we've already mentioned, the real importance of incorporating lived and living experience alongside kind of professionals in the system redesign process, and the real need for structural changes to address fragmentation and siloed care. the importance of culturally responsive, low barrier approaches, and also sort of the critical role that policy will play in creating conditions for meaningful system change. And so, we both really want to highlight that these are critical to how we move this forward. And we see our work as contributing to sort of some form of a blueprint to support these changes in the province and hopefully in other areas. Thank you so much for listening to our talk and for participating in kind of hearing us out. We'd like to thank all of the participants for sharing their knowledge. Michelle and I both have full reports that are available, and we're more than happy to take questions on any questions you might have on this work. And just want to acknowledge Advancing Health for the opportunity for us to come and present today.